And welcome to exam 3, NUR 203. Lots of chapters, lots of information. Let's break it down. Okay, head injuries. Head injuries are something that happen quite a bit in children, right? The thing with head injuries is how to evaluate them. Know that head injuries at the time, there could be nothing, and they subsequently in time get worse. So knowing that if a injury is getting worse over time, then there is something that needs to be done, whether called a neurosurgery or whatever. So as a nurse, you're going to be monitoring their level of consciousness. This would be that child that comes in, or that adult even that comes in, that says that, let's say they hit their head, they fell down, they passed out. I use the incidents of sliding into third base, hitting the head on the defendant, trying to get in and being knocked out. They get to the emergency room and they seem okay. Then all of a sudden they're saying, so was I safe? Was I safe into third? Did we win the game? Is dad coming? And you've told them that 4 or 5 times already. So that level of consciousness changing, getting more and more confused, is telling you something's going on. Another thing, when you're seeing a child start to vomit and then it's becoming more and more, and it's not related to eating or anything. Another thing, headaches becoming worse. So as you can see, progression, vomiting gets worse, level of consciousness that gets more and more confused. You're going to see them headaches worse, trying to walk and getting more and more unsteady. And the headache that wakes them from sleep, that's a big thing. Also, if you see a pupil, one that's blown, one dilated pupil, that is a neurological emergency. It's telling you there's swelling on the side of the brain and it needs to be released as quick as we can. Now, with head injuries, kids are always bopping their heads and we send them home to watch them. One of the things we don't consider is, what about our adolescents? What if they drive themselves to school? Well, no, they can't then. They really do need clearance before, because they could blank out again. And now they are a hazard on the road. So, level of consciousness getting worse, mental status changes, getting restless as hypoxemia. That means swelling's going where oxygen should go. Difficult to arouse, vomiting more than 3 times. Pupils are not, going the way they should. They're dilated. They're not restricting. There none of those things going on. Double blurred vision, and of course the gait. You're not walking right. Something's wrong in the brain. It's not synapsing correctly. Also, headaches become more severe over time, or it wakes them up from a sleep. And as I said, a fixed dilated pupil, neurological emergency, that needs release of that pressure right away. And if we don't, it'll be permanent brain injury damage. So in children, smaller kids, infants, then you're going to say traumatic brain injuries. I can't even tell you how many children I have seen under the age of 1 that have fallen off of beds, they have fallen off of changing tables, they have fallen off of all different things. So, understanding, how do we assess, is there any damage? Well, number one, infants have a fontanelle. That's going to tell you fluid, and it's also going to tell you any swelling going on in the brain. So if we see that swelling, it's not flat at rest, something's going on. Also, the scalp veins you can see in the front, like in front of the ears, they're big vessels and they will pop out. And it's called distended scalp veins. They're usually, you can barely see them. And then think about this. You have swelling going on in the brain. It's pushing against the brain stem. What is the brain stem? Heart rate, blood pressure, temperature, bradycardia, increased pressure because it's pushing on the brain stem. Good. Meningitis. Meningitis, you're going to see children coming in with certain symptoms, right? The headache, photophobia, neck stiffness, all of those things, right? What are you going to be prepared for and know that you're going to be doing? And that is a lumbar puncture. Lumbar punctures, left lateral, right? We set them up on their sides, the older children, and we do the puncture. Now, the lumbar puncture is done for what reason? Well, meningitis can be viral or it can be bacterial. If it's viral, how do we treat it? And it's what we call symptomatic, right? Uh, Antipyretics, fluids, rest. Simple. But when you put it bacterial meningitis, now you need to place this child on airborne precautions for 24 hours, and your priority is antibiotics on this child. Okay? So, caring for that child with antibiotics, number one, IV fluids and antibiotics, and this is your bacterial one. And remember, their brains are just on fire right now. So, minimal stimulation, minimal lights, noise, it really, really irritates the meninges in the brain and creates such a headache. As I said, droplet isolation, first 24 hours, and then cluster care. Their brains are irritable. It can have seizures if we're going to be overstimulating them. Also, know cerebral edema can happen with any swelling, meningitis, or head injuries, etc. So, you have cerebral edema. You've got all this pressure there. Let's say you fell off the second floor balcony, and I've seen a couple of them, believe it or not. And these children come in and they're swelling in their brain. Now, that swelling's pushing on the brain again. The brain doesn't like it. So we need to decrease that fluid pressing on the brain now. And we do it with mannitol, a diuretic, specific for the brain, okay? Mannitol, specific brain. Furosemide, Lasix, that's congestive heart failure, peripheral edema. Mannitol, brain, okay? So, what are we going to do with increased intracranial pressure? Same stuff we're doing for any sort of head injury, monitoring their level of consciousness, looking for that lethargy, headache, that vomiting, and again, looking for fontanelles on infants. So, another thing that can happen with children, infants, is hydrocephalus. It's one of the reasons why we do head circumferences every assessment to make sure that scalp isn't getting bigger and bigger. So if we see in that head circumference is getting bigger, then we're going to look at that fontanelle, right? Probably that's getting bulgy now too. Now, one of the things about hydrocephalus, or a bigger head, a bigger brain, increasing head circumference, it's not always fluid. Sometimes it could be an abscess. So there's something called a Macewind sign. And when you tap on it, you hear this resonating ping with it. So if you hear that ping, then you know it is, the hydrocephalus or the brain tumors going on there. So again, Macewind sign is something to detect the hydrocephalus or a brain abscess in a child. You can hear basically that extra fluid that's in that brain. Another thing we can see with too much pressure in the brain is those eyes are called sunsetting. And I love the eyes. That really depicts it. The eyes start going down because the pressure is pushing it over and pushing the eyes down. Increased pressure in the head, you know you have a headache. But number two, you're vomiting. All part of increased pressure in the brain. What we do for infants is we put in something called a ventricular peritoneal shunt. And this is placed up into the fourth ventricle in the brain. And it's a little catheter, and it goes behind the ear, down the front of the chest into the peritoneal cavity. And it's just this constant dripping of extra cerebral spinal fluid so that your head doesn't get big and cause pressure. Now, what is our care? What do we need to know about this? Well, any child with ventricular peritoneal shunt who's complaining of vomiting and headache has a shunt that's not functioning correctly. They need care now. They usually need x-rays and surgery to repair it. It could be a disconnected or could means they're getting too big. They need a bigger one or a longer one. Okay. The other thing, we're going to measure head circumferences on these, making sure, is the head getting bigger or smaller? We need to know. Also, behind the ear is like a little lump from the ventricular peritoneal shunt. It's actually a pump. We don't touch that. Leave it alone. That actually, the neurosurgeon plays with that one. No, we measure head circumferences, abdominal circumferences, and look at any sort of vomiting, headaches in the head. That's what we would look for. Any symptoms of increased pressure. Okay, another one that we have is a neuroblastoma versus a nephroblastoma. Remember in the cancer section, we talked about a nephroblastoma. By the time you know that you've got a tumor there, we usually are all the way up already into the brain. We also have Wilms tumors, right? Which is a nephroblastoma or a kidney tumor. So, kidney tumors, what do we need to know about them? Well, anytime we work with kidneys and tumors, you always need to be concerned about blood pressures. Even with chronic renal failure, you worry about blood pressures, right? Well, you're going to be worried about this also with a child with a nephroblastoma. Okay, so if we're worried about blood pressures and if we can't get that tumor out, we still need to control the blood pressure. So this child usually would be admitted preoperatively to get surgery. What is our nursing care? Well, before surgery, we still have a tumor. We're still going to have this catecholamine release, which increases blood pressures, increases heart rate, right? So we're going to be monitoring the vital signs. Also, we're going to be given an oral antihypertensive drug to keep the blood pressure down. And one of them that we use is called enalapril. It's an adult medicine. We just do it in pediatric dosaging. Now, seizures. What is a seizure? I basically say it's a something in the brain sparks and goes bzzzt, and it creates wherever that brain is, you see these outward symptoms, right? So your brain sparks, and then you're going to see, the movements, the heads, et cetera, et cetera. Seizures can be due to almost anything: infections, hemorrhage, lesions, tumors, metabolic problems like Tay Sachs has to do a big one with seizures in children. Trauma, of course, any malformations, genetic disorders, toxic ingestions, fevers, all of that stuff can cause a seizure. Now, in children, there's two types of seizures. There's what we call generalized and focal. It used to be petit mal and grand mal. When we talk about seizures, and we're talking about the care of seizures, we're mostly are talking about the tonic-clonic or the grand mal. That means total body is in a seizure. These children lose level of consciousness. Many of them vomit, arms and legs violently jerking and shaking, foaming at the mouth, and maybe vomiting there too, right? That's what we talk about with that. Yes, we do have other types of seizure that you're just looks, maybe an arm, maybe a finger, etc. But when we talk about it, treatment, it's that grand mal one. So you walk into a room, child's having a tonic-clonic seizure. What is our job? And it's what we call safety. We need to get that child safe and we need to keep the airway open. So, what do? We basically get all of that sharp stuff in the bed away from them. Children, always, everything's in the bed with them. So they've got pens and pencils and whatever else in there. And them shaking, they could really hurt themselves. I would take it and usually just shake it, took it and just wipe it down to the bottom of the bed so that it's out of the way. Throw it on the floor, sometimes they might trip on it. So to the end of the bed with all those toys. Then side rails up, pad them with blankets or pillows, whatever you have. put that bed flat, and then turn them on their side. And the reason is if they vomit, it comes out. Never, never put anything in their mouth, of course, but that vomit, you can suction it out, right? And we can keep the area around the mouth and their airway clean. And that's why we have suction at the bedside. Now, sometimes seizures go on and on and on, and it's basically called, status epilepticus, right? This is seizures that don't stop. If that happens, this child will need an IV and we'll get some medications for that. They usually start with a benzodiazepine like diazepam, and then they'll go into some anti seizure medicines, phenytoin, and other stuff they might use. But priority treatment in seizures is safety. Now, when you go home, one of the things we forget about, children go home, you think they're home and they're healthy, and we don't do this teaching. And I know I'm one that I don't believe I did. What about a child who goes and knows how to swim and goes off into the ocean or into a pond, and mommy's on land and they have a seizure? you know, 200 yards out. You can't get to that child quick enough. So please be careful when they're doing sort of outdoors things. Keep them safe. As in, if they're outdoors in a pool, somebody should be with them, or in an ocean, somebody should be with them, or if they're out there playing, somebody should be there because they can have a seizure and they don't know they're going to have a seizure. So keep them safe. So the pituitary gland, it's two lobes. One has to do with growth, and that's the anterior pituitary gland. And the other side, posterior, has to do with fluid balance. So when we talk about hyperpituitarism and growth hormones, um, and hypopituitarism is, how do we, number one, know that they're not growing enough, whether not enough or too much? Well, that's why we do daily, heights and weights every time you walk into a doctor's office. So let's say you have a child who is very, very short in stature. Now, the mother wants to do growth hormones and get them up to, other kids the way they should. Well, it requires big commitment. It's a daily subcutaneous injection. It's like giving insulin every day. So it really takes a big commitment. Okay. Another thing, what if you have a child who's short and they want to get taller, but their whole family is short? It's not going to happen. So you can't change genetics. If they're going to be short, they're going to be short. But if they're short in a tall family, that we can get that child taller. Okay, the other lobe, the posterior lobe of the pituitary gland, all about fluids. So what it does, it secretes a diuretic hormone. So polyuria, polydipsia. So an anti-diuretic hormone. So in diabetes insipidus, it doesn't get enough. So what happens is your urine goes away and it keeps urinating, and then you're thirsty, 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 urinate, urinate, urinate. So one of the ways that we diagnose this is take away the water bottle, and they still urinate like crazy. Another one we do is with infants, we give them a bottle of water instead of their milk, whether formula or breast milk, and it actually stops the urinating. So then we know it is diabetes insipidus. How do we monitor diabetes insipidus? Intake, output, daily weights. How do we cure this stuff? What do we do for it? Well, we give something called vasopressin. The other name is called DDAVP. Many times they have IV, but they also have a nasal spray. So this child has diabetes insipidus. It's lifelong. This is not something that's cured. You have to live with it. So what we'll do is get a daily hormone replacement, all right? Then that's not working. We're starting to urinate a lot. We're going to give ourselves the DDAVP, the vasopressin at home. How do we know it works? The urinating stops. The thirstiness stops. You're not thirsty. You're not urinating. The medicines get is working now, okay? One of the things that alerts us to possible diabetes insipidus is, this vasopressin. Sometimes we use that for children with bedwetting at night. It's another way of using it. And then we have the opposite syndrome of inappropriate antidiuretic hormone, which means too much antidiuretic hormone is being produced. So let's just take the word antidiuretic against urinating hormone. I'm not going to urinate. I'm going to gain weight. So what do you think the treatment is? INO, strict INO, daily weights, fluid retention, salt restriction. Anything fluid retention, any condition, that's what you would say. Good. So diabetes type 1. Now, children that are young that get diabetes are always type 1. And they will always be a type 1 because once the insulin's not there, it's never coming back. It's one of the things that some students think that, oh, when they grow up, they're going to grow out of it. You don't with diabetes. Now, if they're an adolescent that's overweight and has these sort of things and they're into diabetes type 2, we can, reverse that, but never type 1. The one thing about diabetes in children, it's you're hungry and you're thirsty and you're urinating. Remember, diabetes insipidus has nothing to do with blood sugar. It's just fluid, thirsty, urinating. When it's diabetes mellitus, this is the one where you're not digesting sugar, so you're hungry. And that's why the third P is in there. If you can remember it that way, you'll never mix up, is it 2 Ps or is it 3 Ps? Because in diabetes mellitus, you're hungry. So you keep eating, keep eating, keep eating. Your sugar's not used. You keep losing weight. You then, of course, get nauseous, vomiting, and then you're going to smell like fruit. You're going to smell fruity because you're full of sugar. So one of the things that we diagnose these children with is weight loss and then bedtime wetting. So again, another one that we look at to see, is it something that, with bedwetting at night, some children always do. That's all right, normal. What if a child never or rarely has a bedtime accident and now they are? This is something you would check for. You would check their hemoglobin A1C, making sure what was their A1C during the time, the last couple months, is it the blood sugar or not? Another thing about diabetes, when you have a mother who's diabetic and the babies are born, you've got to be very, very careful with their blood sugars. You monitor them closer because they do drop really quickly on them. So they actually get a little sugar water quicker than most other of the newborns. Another thing to think about is you have an adolescent, has a BMI of 92%, and it's been urinating more than usual. What diagnostic test might you anticipate? Well, let's look at the total picture. It's an adolescent who's overweight. What causes overweight? Well, that could be diabetes, so that could be urinating, or it could be a urinary tract infection, or it could be any other thing. What am I going to do? Hemoglobin A1C for sure. I want to see, is this something that's been long going? I'm going to do a regular urinalysis. Just be an infection, right? Urinating more than normal. And that's what I would do. And of course, with urinating more, I would do an electrolyte, checking the potassium. Hyperglycemia is when they smell like a rotten peach that's been in the refrigerator for 2 months and it was lost. And you open the container and it's this really sickening sweet smell. Once you smell a DKA patient, you'll never forget it. It's very distinctive. So you get this child in, what do they look like? Well, usually their blood sugars are above 500, usually 6, 7, 800. I've seen them to over 1,000 before. They come in, they're drowsy, they're not really alert. They just don't even want to hold their head up, and the smell is insane on these children. So, what is our treatment for diabetes? Well, when we have hyperglycemia, your job is immediately fluids and regular insulin IV slow drip. That's DKA. And then, of course, monitoring the ketones in their urine because DKA is hyperglycemia with ketones in the urine. Okay, that is the definition. Now, in low blood sugars in children, it depends on patient condition. Are they telling you they feel jittery, or you're looking at them, they're unconscious and sweaty? I mean, that is the decision. If they're awake and they're saying they're nauseous, vomiting, jittery, restless, shaky, sweaty, dizzy, all that, okay, give them something by mouth. You could give them a glass of orange juice, a glass of milk, a hard candy, a package of sugar, honey over the age of 2, high sugar, quick. But if the child is unconscious, you need to give either glucagon or D50. That's usually the child in a hospital that we consider those things. And if you give glucagon, be prepared, turn them on their side, they're going to vomit. Now, let's get into some of the hormones. And this is where a lot of confusion comes along. So, adrenal. Adrenal has to do with cortisol and it has to do with aldosterone and it has to do with two different diseases. Cushing's is too much. Usually, Cushing's is due to child be given oral steroids like prednisone too much for too long. And what happens is there's symptoms that you would see. They gain a lot of weight. The arms and legs are skinny because of the protein wasting. Okay. But big round face, red is called ruddy cheeks. They're red. They're sort of smushy red. That's ruddy. Hair on the chin is sometimes that you see it. Big abdomen, pendulous, they call it. You can even have some striae in there. But it's that big moon face, that ruddy chin, that big abdomen, and then the skinny arms and legs. How do we reverse Cushing syndrome due to giving too much steroids for too long? We taper it off. I actually had Cushing syndrome. It took me a couple months to taper off of prednisone because you've got to do it slowly or your body does not like that. So these are the things: excessive hair growth, moon face, red ruddy cheeks, weight gain, puffy around face and trunk, that big abdomen. And then remember steroids, poor wound healing, ecchymosis, and of course blood sugars, right? Anything with steroids, you got to be careful with those three things. The other side of the adrenal thing is not enough cortisol and aldosterone. And forever, this is at birth, they don't have enough cortisol and aldosterone. And what happens is the child doesn't know how to assign itself a sex. They have mixed genitalia. You're going to have a penis with a vagina, testicles with a vagina, all mixed up stuff. I've only seen one in my career, only one, but it was very significant. These children, number one, you have to assign a sex. Are you a boy or girl? What I saw happen is they did ultrasounds and they did hormone tests first, and then they assigned the sex. It was a better decision to make. But everybody's different, every parent, every physician, but they have to assign it. They also have a lot of trouble with hyponatremia and hyperkalemia. So we really do need to be monitoring electrolytes and the treatment. They don't have a cortisol, they don't have steroids. We need to give it to them. So we'll be giving it that or aldosterone, what they need in order to function. Now, hyperthyroidism. Hyperthyroidism is too much thyroid hormone. And what happens with too much thyroid hormone is the body doesn't like it. So initially, we just give them some medicine to block the amount of hormones that are being secreted. One of them is called propylthiouracil. I call it PTU. It's usually labeled PTU on the bottle. And it is something that we give to children and adults to stop their thyroid from overproducing. Now, there is a side effect. And PTU, this medicine, can cause leukopenia. Do you know what leukopenia is? It's a low white count. It's more susceptibility to infection. So you would see a child with a fever or sore throat. If you did, that person would have to call the doctor. You can't just say that it's, oh, I just got a cold. It could be the medicine. So that's something these patients really need to know about. Another thing with hyperthyroidism, it could be a storm. It could be too much medicine or a release of too much medicine. You could double dose, could cause a thyroid storm. And that's when your heart rate goes up. You just get tight in the chest. It's a horrible feeling. You get hyperthermic, and it is a medical emergency. You need to go get beta blockers and go to the ER, et cetera, et cetera. It's a big, big deal. Now, children and hypothyroidism. Now, thyroid dysfunction, we can find that at birth. You would see a child that wouldn't have a stool. There is Hirschsprung's disease, there's thyroid disease. These are two of them that at birth, and cystic fibrosis. These are three diseases that if we didn't know, you would see no stool for the first 24 to 36 hours after birth. And then we would test them for all of these things. Now, if we didn't test that infant at birth, this child would be cognitively delayed. Children need, and the difference between adults and children and thyroid is children need it for growth. Adults don't need that, right? But children need it for growth and cognition. They need it to think properly. Now, a lot of the other symptoms are just like adults, which is dry skin, puffy around the eyes, sparse hair, constipation, cold intolerance, sleepiness. You're tired all the time. Low thyroid. I'm tired all the time, right? That's part of what is said. And mental decline. So just like adults, how do we treat thyroid dysfunction? Well, we're going to be giving their medicine. Remember, it gives them a boost. Remember, hypothyroidism, you're tired, you're more lethargic. The medicine helps boost them up. Give it in the morning. If you give it at night, they'll be awake all night long. Another thing is to increase fiber in the diet because of the constipation and fluids. Fluids help with constipation, part of it. It's a nice picture of it. If you want to go down and look at it, just splits hypo and hyper. Now, vomiting, GI vomiting. So you've got a child who is vomiting. Remember, there is one question to ask any small child under the age of 3 months. Is it dribbling or is it across the room? There are two different types of vomiting, right? So this child is just vomiting, it's been sick, it's just dribbling and a little bit more, and it's just started. So some sort of gastroenteritis is there, right? So children and dehydration is extremely dangerous. So, how do we see dehydration in children? Remember that infant, that fontanelle, if it's sunken, we know that is. And that's just sitting there at rest. Sunken, we know. And then, like any child or adult, elevated heart rate, lower blood pressure, decreased or no urinary output, prolonged, slowed capillary refill. Infants, when they're dehydrated, they cry and they're making the noises, but there's no tears in their eyes. And I think that is just so sad, seeing a baby cry and no tears. And the other thing is skin tenting. You pull the skin up and it just sits there. So, how do we treat vomiting? Well, you're not going to give them anything by mouth because they're just going to vomit it right back. So, when they are vomiting, you start an IV. Remember, IV fluids should never be with potassium, should never be with dextrose. You can't bolus them. You can hang them up after you have bolused that good fluid on them. Okay? Now, when you get to the point of you've given them an anti-nausea medicine, given them a bolus, they're ready to eat, now they can start with Pedialyte, Gatorade, or Powerade. Remember, dehydration, children, is extremely dangerous. So, when they're vomiting a lot, number one, you stop them, make them NPO, right? You are going to be starting an IV and getting a lab specimen. When you do the IV and pulling the lab, you need to get electrolytes, the metabolic profile. Where's my carbon dioxide? Where's my sodium, potassium? That's important. And again, when you're starting that IV bolus, never with potassium, never with dextrose, and then you could add the maintenance on later with the potassium in it. Now, potassium can never be started on a child or an adult until you know they're urinating or until you have a potassium level, because potassium in an IV can kill a kidney. So we're very careful before we start any potassium that we know the kidneys are functioning. Of course, with vomiting, you're going to have them suction at the bedside in case they vomit, and of course, turn them on their side if they're vomiting. Now, GERD, reflux, gastroesophageal reflux. This is something that happens in some children where they just spit up a little bit. Now, the problem with infants is when they're spitting up every meal or every feed, they're losing calories. And they took all that energy and burned all those calories in order to eat that food. And now they're vomiting a little bit by little bit. So they're losing calories. So with infants, what we want is to prevent any calories from being lost. So we're going to thicken the feed with a little bit of rice cereal. They actually put like 1 teaspoon in 1 ounce of milk, whether formula or breast milk, and it thickens the food just enough to hold it down. Now, these are new infants, and you're going to say we're not supposed to feed them yet, right? Well, they're losing all of this food every time they eat. That little bit of spit up. That little bit of rice cereal is going to hold the food down. So in the long run, they're gaining calories. They will absorb a little bit of rice cereal, not all of it, but they're gaining the calories. So it's a win-win situation. Now, older children like me and you, I'm an older child with reflux, right? You're going to hear them coughing. It's that mini aspiration cough, is what you're hearing. And you're going to feel that heartburn. Children, infants start out with just rice cereal, thicken it. They will start every single med an adult will take slowly, one at a time. They'll start out with famotidine to stop the acid production. Then they'll go into all of the proton pump inhibitors and all of those things in pediatric doses. Still, there are children that continue to burn their esophagus through refluxing, and now it becomes serious. So they have to stop it now. Medical's not working. They've got to do surgical intervention, and that is called a Nissan fundoplication. That picture shows the upper stomach sort of sewn up onto the esophagus. You can't vomit. They use this when they put in gastrostomy tubes because you're putting in a large amount of fluid. So that's a lot, but they can't vomit it, so you know it's safe. They're not going to aspirate. Nissan fundoplication. Now, that pyloric stenosis is that across the room vomit, like The Exorcist. I have taken children that are vomiting, turned them towards a garbage can 10 feet away, and they will hit it with a projectile vomiting. This little 7, 8 pound child. Yes, it is quite impressive. So, you know, that child is pyloric stenosis. So, what is our treatment for pyloric stenosis? Well, the food goes down, it gets stuck because that valve is tight, so it stays in the stomach and it can't get into the small intestines. The pyloric valve is just thickened and muscular. So they vomit. So now their stomach's empty. So from now on, you make them NPO. They're not going to vomit again because there's nothing in there. You'll do the ultrasound, you'll find out what's going on, and usually, pyloric stenosis is somewhere between 3 weeks and 3 months. And I'll tell you, the sweet spot is 7, 8 weeks old. That's where I see most of them, where they're with this projectile vomiting. Your job, make them NPO. They're infants. They need IV fluids. They need sugar in it, just a maintenance to keep them hydrated. It keeps that valve plump. So when they do surgery, it's easier and maintains their blood sugars. Now, liver problems. Now, the liver is connected to the small bowel through the common bile duct. So it's part of the GI system. So we talk about hepatitis. Well, hepatitis is an inflammation of a liver, no matter what letter hepatitis it is. So, what is our problem? Bile is in the liver. We need bile for digestion of fat. You don't have bile, you're not digesting fat. What happens when you have fat and you eat it and it doesn't get digested? You get bloated, you get gassy, and then you just lose your stool. It's going to be gooey and full of fat, right? So, hepatitis, what is a nursing thing? Well, we know it's infectious. Hand washing, always universal. You assume everybody has some disease. Hand washing, and then, of course, gloves when you're going into any sort of, stools or urine, whatever. The big thing now is diet. So you cannot digest fat. They don't have bile. The liver is messed up. So high protein, high carbohydrates to try to make up for all of those fat calories. And then, of course, low fat because I don't want to have all that gas and bloating. And good choices of low fat diet. Milk, fish, meat, fish, fruits, vegetables, and milk, and I would say is skim milk. Another thing that has to do with diet, very similar, is celiac disease. Now, celiac disease is when you ingest something that has gluten in it. Gluten is present in wheat, rye, barley, and oat flours, which is a lot of everything. It's all your breads, all your breadings on all your fishes and chickens and all that stuff, all your macaronis and spaghettis. And these things, these children cannot eat. Another problem with celiac disease is these children do not digest fat. So, again, what are you going to see? Well, we're going to see that abdominal distension, that gas. But we call this stool steatorrhea. And that is because it's all fatty that's being passed. And it's pale and it's bulky and it stinks to high heaven. When you talk about hepatitis and bile problems, it's a very pale stool also, so that's very similar there. So for celiac disease, what do we do? Well, we just eat properly. And if you eat properly, um, the pain's not going to be there. But again, high carbohydrates, high proteins, low fat in this diet. And if we need to do any sort of um, like uh, wheat or rye, rice, they have rice flours and rice things out there that are really good right now. But remember, celiac is a lifelong commitment, and we do it by maintaining a good diet with no gluten. And then these children should gain weight with, the increase of fat, excuse me, protein and carbohydrates in the diet. Now, allergies are part of the GI system. We eat food and we have an allergy from it. That's why we wait so long in between feeding, infants a new food. We get one food every 4 to 7 days. Now, what would be a food allergy? It could be as simple as a rash. It could be vomiting. It could be diarrhea, abdominal discomfort. Okay, that could be an allergy. Another thing that we have is the intolerance. Some people cannot have lactose, right? And they have all of the gas and whatnot from that. So again, if they can't have a certain food, we have to remember to replace it with something else. If we can't have vitamin D and calcium from milk, we need to look at where else can it come from. Now, Hirschsprung's disease. Hirschsprung's disease is a congenital megacolon, which means it's an intestinal obstruction. It is an area in the descending colon where nerves don't form. If there's no nerves, what we see is the peristalsis, they don't work. There's no nerves to do it. So it sits there. What's ever in the intestines sits there and gets bigger and it gets bigger and it gets bigger. And you're going to tell me that hurts. There's no nerves. It doesn't hurt. So this would be another no stool at birth. First 24 to 36 hours, we'll be doing an x-ray, making sure it's not a Hirschsprung's disease. Well, sometimes because of that little skinny little area that can go to the rectum, sometimes you have little ribbon stools coming out. Okay, like a little frosting thing is what I assume it to, like a little like that. You might see that. No stool. We're going to be doing that x-ray, and we are going to be treating this with a either a colostomy, or we might be able to pull it through, which means we connect it immediately to the bottom. But that all depends on what's inside. Now, they do like to do this before the child is potty trained. Okay, so that's the big thing with Hirschsprung's. And if we are working with the intestines, descending colon, we need to postoperatively, no matter what, no rectal temps, leave it alone. Also, because of the amount of manipulation inside the intestines, these children have to be maintained NPO for several days to rest the belly, to rest the intestines after all this manipulation. Now, enterobiasis, this is pinworms. Children go outside, play in the dirt with long nails, and little eggs get caught underneath, and then they put their hands in their mouths, and now we've got worms. And of course, this can go to the entire family. It's really contagious. What would you see? This is intense perianal itching and scratching. And because of that, and they're itching and they're moving and they're trying to scratch their butt, they don't sleep. So the doctor says, please, would you collect me a worm? And how do you do that? Take a piece of scotch tape and a flashlight, go at night when it's dark, and go on the anus, put the scotch tape and pick it up. And usually you'll get a little tiny little worm, and then we can, confirm it. If one kid has it, you need to check everybody to make sure the whole family don't have it. And how do we prevent it? Keep the nails short. That's the best we can do. Now, esophageal atresia, tracheoesophageal fistula. This is two things that affect food that comes into the mouth. Where does it go? Esophageal atresia, A without. Esophagus doesn't go anywhere. There's atresia, no connection to the stomach. So you eat, it sits there, and where does it do? Comes back up and you vomit, you gag, and you choke on it. Tracheoesophageal fistula, we put them together because their treatment's the same. If you were to feed this child down the esophagus, it's going to go across that fistula and you're going to aspirate right into the lungs. So, both of these children at birth, gagging, choking, because they can't tolerate secretions. They might even look a little cyanotic. If you feed them, you're going to hear them gagging and choking on the first swallow almost. So that would be the clue, right? These children, our biggest concern is aspiration. So, treatment for these children, head of the bed elevated. You keep suction there. Now, they're going to be spitting it up, so you try to keep their mouth clean, but NPO, they still got mucus in their mouth. They're still going to have many aspirations there, right? So, IV fluids, and this one, not pyloric stenosis. No, it doesn't. But the TEFs, because of the chances of aspiration, we will give them antibiotics prophylactically, not pyloric stenosis. They vomited, they're done. There's nothing to aspirate. Their stomachs are empty. TEF, they're swallowing mucus constantly. They're constantly mini aspirating. They need an antibiotic. And then the big thing with growth, development, and infants, because this is birth, give them a pacifier, a non nutritive sucking. That keeps them calm and gives them, that they need to relieve their stress. Now, acute appendicitis, children come in right lower quadrant, McBurney point. We do ultrasound. All right, they have an appendix. Children with an appendix, they walk in most of the time, hand on the right lower quadrant, bent over, and they limp on the right foot. Like, oop, that is an appendix. You can really see it. So, when we figure out that's what it is, number one, make them NPO, get the ultrasound. All right, we have to go to the OR. So, NPO IV fluids. And because an itis is an infection, we give antibiotics before prophylactic. And if they have any pre op meds, they can be given for appendicitis. Now, what if that appendix bursts before we get there? Treatment post-op is completely different. If it didn't burst, these children would be on IV fluids, wake up, start clear liquids, and they would be home later that day almost. When it's peritonitis, now you've had an infection that's scattered throughout your peritoneal cavity. That appendix just burst, and all that stuff is really irritating the intestines and the whole cavity and all the organs. So we need to rest the tummy. NPO, we also put in an NG tube. Why? We don't want anything going through that intestines, hurting and upsetting that intestines that already's been spewed from the outside with all the contents from that appendix. We want to rest it. So NG tube to keep the stomach as empty as possible. Of course, with NG tubes, you'll monitor electrolytes, depending on how much comes out. Also, you're going to be giving this child antibiotics postoperatively. It's an infection. You gave it pre-op, hoping it didn't burst, but they got upstairs and it burst. So yes, you're going to be continuing them. You also going to be monitoring their lab values, not only your electrolytes, but monitoring their white blood cell count. How bad is the infection? Are the antibiotics working? Are the white blood cell counts coming down on every CBC blood draw? Do you see how it feeds in like that? Another thing, because it was an infected abdomen that you did surgery on, those wound edges are considered dirty. They're not healthy. And when they close the wound and suture it up, that wound is at high risk to dehisce. So assess that wound. It's part of your nursing care there. So NPO, IV fluids, antibiotic, watch that WBC count, pain control. They're not going to get up out of bed, cough, deep breathe unless you give them something for pain. And they're not going to ask. So children, you need to give it. Another thing is you give them something for pain, getting them to cough and deep breathe. If you distract it by making it fun, you'd be surprised how well these children do to prevent pulmonary problems, like doing blow bubbles or a pinwheel. I've told my student, I had one older teenage girl, I had doing spitballs in the middle of the night. And that created so much, peak pressure, and her lungs were horrible. In one day, her chest x-ray improved so much, and the doctors were like, well, what did we do? Yeah, Betty was doing spitballs again at night. So they knew that what I was doing, it's a distraction. It's kids. You can get away with it at that point, right? Now, an omphalocele, a gastroschisis, a bladder extrophy, something was born on the outside, on the abdominal wall, whether the stomach, abdominal intestines, or your bladder. All of those can be born on the outside. What is your job? Well, number one, this child will be on their back on a warmer and they can't be covered. We have to look. So we need a warmer to give them the heat so they can be uncovered. Because the insides are on the outside, we need to cover it with a nice, wet, sterile dressing, normal saline. Same solution as the body, isotonic, normal saline. You're going to make sure that the skin keeps well, because we're going to be shoving that stuff in the surgeon every day to make room for it, stretching out the abdominal cavity to make room for it. If we protect that skin integrity, we can get that wound closed quick. Or what happens if that skin isn't good? There's going to be nothing to be able to close it because the skin isn't good, okay? As I said, no swaddling, NPO, because the insides are on the outside, right? We want to just rest it. We don't want to overdo it. And antibiotics, prophylactic, because the insides are on the outside. And we're going to put, of course, IV fluids to give them, the nutrition they need. Mecodiverticulum. I call this a little piece of skin that outpatches in the small intestines. And inside these little things inside the intestines, there's big blood vessels. And it rips somehow. It tears small intestines. And what happens is that little blood vessel, actually quite big one, drips blood into the intestinal tract. And what you see is painless rectal bleeding. You might see a little abdominal cramping or tenderness, but not much. They go in, they do an x-ray test, and they take it out, and this kids do fine. But the thing is painless rectal bleeding. All right, nephrotic syndrome. We're into GU now. Nephrotic syndrome. Well, nephrotic syndrome is not renal failure. Know that nephrotic syndrome is the kidney saying, protein, bleh, yuck, I don't like you. But they're working. The kidneys are working. So what do you see? You see all the protein in the body going away. And remember, there's protein in the vasculature, right? Protein, the other name is albumin. So if you don't have protein or albumin in the blood, this is going to affect how you give drugs to this child, because you're going to have elevated drug levels because there's no protein for the drugs to hop on. So it's all going to be free floating. It's going to be higher levels. So massive proteinuria, hypoalbuminemia. It messes up with the lipids, going to be increased. And because albumin is not inside the vasculature, the body's trying to make an isotonic, moving fluids around, so it pushes fluids interstitially. That's why these children have generalized edema when they're really in a bad time where the kidneys are really not working as well as they should. So, nephrotic syndrome, nursing. Well, this is a fluid problem. What do I need to do? Intake, output, daily weights. You'll hear me with fluid, intake, output, daily weights. Also, because this child is retaining all this fluids, we need to do a salt restriction so we get rid of as much fluids as possible. And of course, a fluid restriction. Acute glomerulonephritis is due to strep infection, just like rheumatic fever, right? So rheumatic fever is a valve problem. Acute glomerulonephritis is a kidney saying up and shuts down and stops working. So kidney's not working, not urinating, swelling, blood pressure goes up, and this is periorbital edema. And because blood pressures are going up, swelling, now we're having headaches. Remember, acute glomerulonephritis, if they're having severe headaches, that blood pressure could be to the point of stroke. Make sure you check that blood pressure because it could happen. You're going to see hematuria, proteinuria, and we treat this by just intake, output, daily weights, salt restriction, fluid restriction, and steroids will help this one. I mean, not steroids. You're going to treat the strep. We're going to treat the infection. So that's the answer to the whole thing. Daily weights, I&O. We can measure the abdominal girth because it's the belly where the kidneys are. And again, low sodium fluids. And these children are susceptible to infection. It's autoimmune. So doing a kidney biopsy, I call it very similar to a cardiac cath because there's similarities here. Preoperatively, they're made NPO and they're sent to the procedure. Most of the time, they're giving a little sedation. Younger kids are knocked out more. Infants might get a little incision because the kidneys are so small, it's hard to see it. And this is on their back. On your back is where your kidneys are. So you turn you on your tummy to do this procedure. Post-procedure, we have stuck a needle inside the kidney. We're worried about urine, we're worried about blood. So pressure dressing for to monitor that. Also, just like cardiac cath, bed rest 24 hours because it was hitting the kidneys. Look at the tummy, making sure no urine blood's going in there. Monitor intake output because it's kidneys. And of course, there's incision on infants, and of course, any incision you'll look at. Renal failure, a big thing with this is to try to keep these kids as normal as possible. Again, it's all about intake, output, daily weights, monitoring fluid electrolyte balances. Another concern with renal failure is erythropoietin is really not made, so we can give erythropoietin injections, and that will decrease the amount of blood transfusion. So we do that on renal failure. Peritoneal dialysis. This is usually first line treatment. This is for your young children. Young children cannot be on hemodialysis. The flow in and out is too much for their brains. So they must be on peritoneal dialysis. They take fluid, they put it inside the peritoneal cavity. It sits there for an amount of time, and then it drains out into a Foley catheter bag. And they do this 8 to 10 cycles. And then whatever in the Foley catheter bag, you subtract for how much fluid you put in. That's your urine output for the day. What are you going to do and monitor? Well, You have one kidney, and that's the peritoneal cavity. You're going to make sure it doesn't get infected. So you're going to make sure any color change of dressing, a change of fluid, redness, any of that, you're going to call the doctor immediately because you need to treat it immediately. There's no other kidney for this child. So we have to take care of that tummy. In this week's lecture, scoliosis. Scoliosis is an S-shaped curvature. This is usually your adolescence beginning, that pre-adolescent growth spurt where they do get really, one shoulder goes up, one goes down. Know that adolescents are in that identity phase, disturbed body image. I've got to wear this brace. What? They've got to wear it 23 hours a day. They take it off the shower and they put it back on, but they can do really well. Now, there's different sorts of scoliosis, and it depends on severity of the curve. If it's less than 45 degrees, they can just do conservative physiotherapy and a brace. They say to put a cotton t-shirt underneath the brace because it's like plastic, it's hard. They don't want it rubbing and creating friction there. So that's why they put that underneath. And no lotion underneath there. So again, scoliosis under 45, we do just conservative treatment. If it's bigger than that, they will do scoliosis surgery, like a Harrington rod. They actually put a rod down the whole spine and they connect it. And this is that one patient that you log roll because they have to be in bed rest flat post-operatively. So that's turning them over, pillow between their legs, two people all at once with a log. Now, developmental dysplasia of the hip, we usually see this in your infants. This is why the first visit they take the knees, push them up, and pull them out. They're listening for a click. They also put them on their tummies, looking to see if their gluteal folds are equal. And if we're seeing clicking, a shortened limb, the folds are crooked, this is a developmental dysplasia of the hip. How do we treat it? Well, we have learned that infants' bones heal extremely quick. As we get older, it takes more and more time to heal, but infants are quick. So, the quickest we can get on this thing called a Pavlik harness, we make the hip abduct. It creates abduction of the head with a B, abduction. And just like the scoliosis, this brace must be on 23 hours a day with a cotton t-shirt underneath because of the motion. We don't want to have any sort of rubbing there at all, okay? Another thing we have for developmental dysplasia of the hip, let's say this Pavlik harness isn't working. We can, if they're older, up to 30 pounds, we can put it in the upper pitcher, which is the legs up. It's called Bryant's traction. The thing with Bryant's traction, you have to be less than 30 pounds, and your buttocks is slightly off the bed. So it's holding it up, 90-degree angle. Types of fracture. We have it from the simple, which most kids do, to open, the complicated, etc. Now, simple is you break it, it's swelling, but the skin is fine. Open, it's a fracture. You can see it, it's swollen, but now we see a cut, a laceration, a break in the skin. The big problem with a fracture that comes through the skin is our concern for infection, osteomyelitis. So, priority antibiotics. It's not pain medicine, it's antibiotics. Yes, they have pain, but I want to prevent severe infections. That will always be priority there. Complicated, damaged organs, that could be a fractured rib, right? Comminuted, small little fragments everywhere that probably need surgery and clean out with that one. An avulsion, the bone pulls away from tendon or ligament, and that's going to need rest, etc., to be fixed. And then the one that could be spiral fracture, could be child abuse. They take the hand and they twist it and they pull. They twist it and pull, and that could be hands or feet. We have seen them both places. So these are our tractions. I just went over Brian's traction. As I said, if Pavlik doesn't work, it's going to go into the Bryant's, and it is for that. Hip dysplasia, some of the other ones, lower extremities, we have Buck's traction and Russell's traction. You hear Buck's traction, you think adults, you think of a fractured hip, right? In children, we think Buck's traction is used for fractured femurs because it pulls the bones and makes them line up, and it prevents all those muscle spasms and the little sharp edges going into muscles and nerves and creating pain. So, making sure we keep that leg straight, keep those weights hanging freely, and keep the heel off the end of the bed is exactly what we need. And checking the neurovascular signs, checking pulses, making sure blood flow is freely going down. So you get a fractured kid comes in. What are we going to teach them? What are things? Well, put on a cast. We're going to make sure. Where's the pain? Is it what's the color of the fingers if it's in the arm, right? If I can get to a pulse, do we have a pulse or not? Is the numbness, do we have numbness or not? Can we move our hands or not? Or is it feeling like it's swelling? Any of those things we see in it pallor and no pulse, that child needs to get back to where that cast was put on to get it removed. It can cause the whole arm to turn black and fall off if we don't do it right away. So, child comes in, got a cast on. What are we going to teach? Well, number one is to keep the cast dry. As I said, I've seen many kids will come in, get the cast on, and I've seen several children do this, go home, put on their bathing suit, and jump in the pool with a brand new arm cast. And all of a sudden, the mother comes back and says, "You're not going to believe this. He jumped in the pool," and they have to change it. They can't leave a cast wet. It can create bacteria, mold, and stuff to be growing there. So keep it dry. We usually send them home with bags, short arm, short leg, long leg, and small, medium, large sizes. We've got them for them. The one thing is with any fracture, keep it elevated, that rice stuff, right? You're going to rest, ice, contain, and elevate, very similar. Wiggling the fingers or toes, keep circulation going, nothing inside. And that cool air dryer does help some of the students because they want to stick things in there. And at least it gives them some sort of sense that they're doing something. Now, cerebral palsy. Cerebral palsy is the brain doesn't really function the way it should, and it is permanent. It is development of impaired muscle movement, hypertonicity, poor posture, and it creates a movement where they can't move the way that they should. This is all their muscles, whether they're eating or walking, if they can, they take a lot of help with their muscles. So, if you are feeding a child that has cerebral palsy, it's just not their legs or their arms. Remember, they have jaw muscles too for chewing. Remember, elevate the head of the bed. Give them that extra time they do need to chew and to swallow because these kids are high risk for aspiration. So, anyone with cerebral palsy, the key is as soon as we're seeing some sort of delay in those developmental milestones, that's usually what you see. As soon as we know, get them into whether it's speech, physical, occupational therapy, get them into what they need to help them, right? Again, doing all the testing that we should do to see if what is causing it, or is it a metabolic condition? So, children with cerebral palsy. Many of them have seizure disorders, so dental hygiene. Remember phenytoin with gingival hyperplasia, those things, making sure the teeth are good and clean, making sure they get medications on time. Again, these children, if they're in a wheelchair or in a chair, most of these kids can't support their own muscles. Fall risk, big, big fall risk. And again, that after feed with feedings, be careful. Keep them involved, get them out. We've taken kids with cerebral palsy, severe cerebral palsy, putting them in little swimming pools at this PPAC where I used to do clinicals at. And we put all of them, they would splash or we would sprinkle them with water. And the giggling was just so amazing. Don't ever take a brain that you think cerebral palsy that they're not there. You're going to be very surprised the things that you do. I used to do an 18-year-old girl's nails at clinicals. I got permission from the place and from her mother. So every time I went in, I did her nails and she would choose her color. Nonverbal girl, nonverbal cerebral palsy. She would pick the color and the smile when I was done. Okay, that said everything. Don't ever count them out. Remember, you got dosage calc coming. If you need help with it, I've given you dosage calc for this exam. It is the types of questions with different numbers. If you need more help than that, you've got Cahoots. Test yourself now. Do I know what I need to know? And remember to breathe. I believe in you. You can do it. You've put the effort in. You're going to make it. So I wish you all good luck.